Now, let us remember that metabolic syndrome cannot be dissociated with fatty liver. Metabolic syndrome is the underlying mechanism of producing fatty liver and NASH. What is this metabolic syndrome? This is also known as IRS or insulin resistant syndrome. All of you know that visceral obesity is the cause of insulin resistance. The pot belly, the apple shaped figure, the intra-abdominal fat deposition, the visceral obesity is the underlying cause for insulin resistance. This allows the liver to turn into a steatotic liver or fatty liver, which can progress on to NASH. Of course, the other chain of events of metabolic syndrome and visceral obesity are development of non-insulin dependent diabetes mellitus type 2 diabetes mellitus, increase in the triglycerides, decrease in the HDL and hypertension. Remember, metabolic syndrome is primarily because of visceral obesity, abdominal fat, which can pave way for type 2 diabetes, dyslipidemia, hypertension, steatosis, steatohepatitis. And remember that all of these are interlinked, or they are different manifestations of same underlying pathological entity called the insulin resistance syndrome or the metabolic syndrome. There are several definitions that have been advocated for diagnosing metabolic syndrome. All the groups have sat together and finally resolved and formulated a new definition of metabolic syndrome. The first and foremost criterion for metabolic syndrome in Indians is waist circumference of more than 90 centimeters in men or more than 80 centimeters in women. That must be the first criterion. Along with that, any two of the remaining 5 that are listed here will form the diagnosis of metabolic syndrome. What are the 5 other entities here? Triglyceridemia of more than 150, HDL lower than 40 in men, lower than 50 in women, dysglycemia with fasting blood glucose more than 100 or a diagnosis of diabetes mellitus, hypertension of more than 130 or more than 85 diastolic, or patient is under treatment for any one of the above conditions like dyslipidemia or hypertension or diabetes. So, today metabolic syndrome is very simple. The waist circumference has to be measured. This is mandatory for all patients who are above 25 to 30 years of age. If the waist circumference is more than 90 in men and 80 centimeters, more than 80 centimeters in women, we are bound to check the lipid status and then the glycemic status and the hypertension and the treatment history for them. If there are any two of the 5 factors listed here, 2 among these 5, along with increased waist circumference, then that formulates the diagnosis of metabolic syndrome. You can label the patient as metabolic syndrome and start working for preventing the damage that could be caused due to this insulin resistance syndrome. As we have already seen, NAFLD or steatosis or fatty liver, insulin resistance, metabolic syndrome with the other components of insulin resistance like dyslipidemia, hypertension and visceral obesity, and then frank diabetes mellitus. These are cyclical events. NAFLD, insulin resistance, metabolic syndrome, diabetes increases NAFLD, further insulin resistance, further metabolic syndrome, further aggravates diabetes. So, each of them perpetuate the other. NAFLD is the hepatic component of metabolic syndrome. We have not seen that as one of the criteria to diagnose metabolic syndrome, but nonetheless NAFLD can be taken as the hepatic manifestation of insulin resistance syndrome or the metabolic syndrome. Remember, these are a continuum, they are one and the same, they perpetuate one another. Look here, the awful two. What are those two things which cause the metabolic syndrome? Central obesity, abdominal obesity, waist circumference more than 90 centimeters in men and more than 80 centimeters in women, associated insulin resistance. These two together cause the metabolic syndrome and all the metabolic abnormalities. Not only that, those two are the components of metabolic syndrome, they propel each other. If there is central obesity, it increases insulin resistance. If there is insulin resistance, it increases central obesity. So thus, these two are like the two gear wheels here, each propelling the other. So another way of looking at insulin resistance syndrome, insulin resistance occurs, hyperinsulinemia, excess insulin is produced, that leads to metabolic syndrome, inadequate insulin is produced or insulin deficiency occurs, leads to type 2 diabetes. In the initial stages there will be hyperinsulinemia, then there will be hypoinsulinemia. If the patient has severe insulin resistance, there will be hypoinsulinemia and that results in type 2 diabetes. If there is hyperinsulinemia, it leads to metabolic syndrome. This metabolic syndrome and type 2 diabetes are nothing but equivalents of coronary artery disease and they pave way for coronary artery disease. Type 2 diabetes is the forerunner for chronic kidney disease or diabetic kidney, diabetic progressive retinopathy, and then diabetic peripheral neuritis, and then diabetic autonomic neuropathy. Whereas metabolic syndrome, it gives rise to hypertension, which in turn increases the risk for strokes, the PCOS, which is the polycystic ovarian syndrome, and of course the NASH, which is the subject of today's discussion. So these are very much interlinked and insulin resistance is the grandparent. Then what is the implication of all this? The implication is to understand that these are the different facets or phases of the same underlying cardiovascular endothelial dysfunction. These are one. If there is NASH, 98% of the NASH people have insulin resistance. 85% of them have metabolic syndrome. 70% of them have frank diabetes mellitus. As clinicians, if we see NAFLD and NASH, we must evaluate for diabetes, metabolic syndrome, CVD and other cardiovascular profile. If we see these conditions like diabetes, metabolic syndrome or cardiovascular disease, we must look for the liver damage and then identify NAFLD and NASH and start preventing the development of further liver damage. So if we find one, we must look for the other. This is the substance of this slide. Here we need to understand about the very important concept of peroxisome proliferator activated receptors, also called PPARS. Peroxisome proliferator activated receptors or PPARS, they belong to nuclear receptor family, and there are three types of PPARS: PPAR alpha, PPAR gamma and PPAR delta. And there are also what are called retinoid X receptors or RXR receptors. These nuclear receptors and RXR receptors are vasoprotective in their function. PPAR alpha, it is vasoprotective, it controls the lipid metabolism, it increases the beta oxidation of fatty acids, free fatty acids, reduces the free fatty acids, and also PPAR alpha acts as a sensor for the level of free fatty acids, and if the level of free fatty acid is going more in the body, PPAR alpha is stimulated and fat metabolism into carbon dioxide and water is facilitated. If the PPAR alpha function is damaged, then of course we end up with lipid abnormalities. PPAR gamma is important for insulin resistance. PPAR gamma reduces insulin resistance, increases insulin sensitivity. It is most important for the development of prevention of development of diabetes. If PPAR gamma activity is good, development of insulin resistance and diabetes mellitus are halted. If the PPAR gamma activity is poor, then insulin resistance will increase, insulin sensitivity comes down, diabetes mellitus is precipitated. We have drugs which stimulate the PPAR alpha, which are like we use fibrates, the gemfibrozil, clofibrate, fenofibrate, all these are PPAR alpha activators. Whereas PPAR gamma activators, we have the glitazones, the rosiglitazone and the pioglitazone. There are now drugs coming which have a dual action on PPAR alpha as well as PPAR gamma, and these will be in the market in the next few years. And of course, we have the PPAR delta. These PPAR delta are not much expressed in human body. Nonetheless, they are present very much in the Kupffer cells of the liver, and they increase the macrophage function or potentiate the activity of the Kupffer cells in the liver. These retinoid X receptors are the ones which control the PPAR alpha, gamma and delta. If one were to have good activity of these nuclear receptor enzymes, retinoid X receptors are to be stimulated. Their stimulation increases activity of these things, and that is very important for us to understand about this PPAR family and the RXR family. Now we have another group of receptors, sterol regulatory element binding proteins, or also called SREBPS. The SREBPs are a family, and there are 3 CBPs expressed in human body: SREBP1A, SREBP1C and SREBP2. These SREBPs act as opponents to the PPARS. If the PPARS are protective, SREBPs are damaging or detrimental. There is another hormone called the leptin in the body which opposes the action of SREBPs and controls the expression of 1A, 1C and 2. Now there are 30 genes identified in the SREBP family in the human genome. Synthesis and uptake of cholesterol and free fatty acids and phospholipids and triacetylglycerol are controlled by the activity of these SREBPs. If the SREBP activity is more, there will be more of cholesterol synthesis, there will be more of free fatty acid synthesis, there will be more of phospholipids, there will be less of beta oxidation, with the result there will be more of triacetylglycerol. Triacetylglycerol, remember, is not a good product. If the fats are beta oxidated, carbon dioxide and water are produced, no damage is done. If triacetylglycerol accumulates, it produces fatty liver. So the SREBPs increase all of these things, but the action of this SREBP family is opposed by the hormone called leptin.